Hello everyone, welcome to Clinical Knowledge and Medicine. Today we will talk about type 2 diabetes mellitus. Basically, we will talk about the patho of type 2 diabetes mellitus, how can we differentiate type 1 from type 2 diabetes mellitus, then the workup, clinical features in type 2 diabetes mellitus, and the treatment. But the complications will be covered in the next video. So let's start with the type 2 diabetes mellitus, which is polygenetic, and type 2 diabetes mellitus is due to insulin resistance, which is due to beta cells exhaustion. No proper mechanism will be there of beta cells, so therefore insulin will be resisted, and there will be increased levels of adipokines, which is responsible for the weight gain in these patients. And now, due to the weight gain, these patients are mainly obese most commonly, and there will be decreased level of adiponectin, which is the guardian of obesity. So in short, due to the increased level of adipokine, the patient will be obese, and the levels of adiponectin will be reduced, which will not allow the patient to stay thin or healthy. Then this patient might come in your OPD and say, "Sir, look at me, I'm so healthy. So how can you say me that I'm not healthy?" But the patient will be having muscle wasting, and he will not be familiar with this because of his health or healthy body. Now, in these patients, symptoms are mostly not seen. They are asymptomatic, but if they will come with symptoms, there will be, the patient will present with weight gain. Obviously, that will be obese. Insulinopenia can be there or not. Symptoms of type 1 like polyuria, polydipsia, polyphagia will be seen, and we have to ask the patient for proper history. Like, if there is polyuria, polydipsia and polyphagia, these three will favor towards hyperglycemia. Then, in these patients, we will see dawn phenomena. Basically, in this, blood glucose level will be increased 20 mg per dl at end of the night, and this phenomena is not seen in type 1 diabetic patients. Then, physical findings which we will see are obesity, which will be central, abdominal obesity, hypertension will be there. Mainly, hypertension is associated with diabetic patients in type 2. Then there can be neurologic findings like decreased or absent light touch, loss of deep tendon reflex in ankle. Then in eye, there will be hemorrhage. Skin, in skin there might be acanthosis nigricans, candida infections can be also seen. Then in examination further, vital signs will be seen, and fundoscopic examination, in which we will view retina for any retinopathy or any hemorrhage exudates. Then we will also manage foot. Foot assessment is also done, because in these diabetic patients, their wound or any abrasion is present anywhere on the body, the wound healing mechanism will be slow. And if there is foot infection, due to which there will be poor extremity blood flow, and the healing will be slow. So the blood flow at the foot level is dorsalis pedis and posterior tibialis pulses are palpated, which can be present or not. So because of this foot infection and slow healing, the patient might be told for amputations. And there can be cellulitis, diabetic cellulitis in the foot or anywhere else on the body due to trauma, infection or abrasion. Now, how can we differentiate type 2 from type 1? On basis of the history, physical examination and lab test. So in type 2 diabetic patient, that will be mainly obese, may have acanthosis nigricans, hyperpigmentation, which will be seen on the back of the neck and like deeper areas. Hyperpigmentation can be seen in these patients. Then we will check for lab findings. We can have fasting C-peptide level, which will be more than 1 nanogram per dl, and they might have diabetes for more than 1 or 2 years. Then serology, autoantibodies will be seen, which are islet cell, anti-GAD65, anti-insulin, which is not seen in type 1 patients. Now, if the patient is asymptomatic, so how can we diagnose him with type 2 diabetes mellitus? There will be physical inactivity, and by the past history of family history, there will be first degree related with diabetes, and hypertension can be associated. HDL cholesterol level under 35 milligram per dl. There can be history of cardiovascular disease, and if all these are absent, then pre-diabetes testing can be done. Pre-diabetic patients are fasting blood glucose will be 100 to 125 milligram per dl, or 2-hour post-oral glucose tolerance test, in which glucose level will be 140 to 200 milligram per dl, which will be at risk of macrovascular disease, which is coronary artery disease, and these patients will have increased triglyceride level, abdominal obesity, and increased BP. Now the treatment. In type 2 DM patients, we mainly focus on the diet control and exercise. These lifestyle modifications can mainly control the type 2 diabetes, but if these are not helpful, then we will switch on to the therapy or drugs. But these modifications are also done simultaneously with the medicine. So diet control, carb intake regulation should be done. Low glycemic index food should be taken, like oats, egg white, and multigrain breads. Trans fat should be kept 0, like no processed or packed foods should be taken. And the patient should calculate the daily intake of nutrients, like how much fat, how much carb, how much protein intake is there, which can be done with the app nowadays on your mobile. Then exercise is highly recommended, like brisk walk or jogging for 30 minutes is at most like enough for the patient on the daily basis, which will increase the GLUT4 levels, and that will promote sugar entry into muscles, which will result in decreased blood sugar levels. Then if we talk about medicines, these are oral hypoglycemic drugs, which will control hemoglobin A1C, biguanides, which will inhibit hepatic gluconeogenesis, and in this level will be 1.5 to 2% over 3 to 6 months period will be decreased. Then the medicine which is used is metformin, and type 2 patients are mainly obese, so that is the drug of choice. And the dose is 500 milligram, 850 milligram or 1 gram. Maximum dose for day is 2.5 gram per day. Then sulfonylureas, which will decrease the level of hemoglobin A1C by 2%. And then these medicines are tolbutamide, glipizide, glimepiride. Now the long-acting medicines are degludec, which is also known as nighttime insulin, because it has longer duration of action, more than 24 to 42 hours. So preferred for the night time. And then there is a drug which is given once a week, which is Ecodec or liraglutide, which is expensive and is given by the parenteral route. So this was all about type 2 diabetes mellitus. Thank you and subscribe the channel.